So I was going to touch on the NICE quality standards, which is the National Institute of Clinical Excellence. And these standards were first published in 2016 and revised in 2023. And if a service was going to break down sort of just to look at, what are the nitty-gritty standards that we need to deliver, these 6 standards are quite good to start looking at and reviewing services. The first one emphasizes starting early, so planning by the age of 13 to 14 years or immediately if they enter the children's services, having a transition plan that is coordinated, reviewing the transition planning annually, having a named key worker that the young person recognizes and can approach and discuss their healthcare issues, especially during transition. And this could be any healthcare professional that the young person is comfortable with. Meeting the adult practitioner from the adult services before transferring care, ideally. And then if the first meeting or appointment in the adult services is not attended, that the young person is contacted by the adult services and given further opportunities to engage. This is a just one slide summary of a 5-year research program which was NIHR funded, and this is about facilitating transition, healthcare transition for young people with long-term conditions from pediatrics to adult healthcare, and this was a 3-year longitudinal study looking at over 300 plus young people across different conditions, and they looked at sort of the possible beneficial features of healthcare transition. And there were 3 features that were associated with improved outcomes, and these were appropriate parental involvement, both from the perspective of a healthcare professional, but also from the perspective of a young person. And it included the concept of starting to give young people sort of opportunities for seeing healthcare professionals independently. It was around promoting a young person's confidence in managing their health and meeting the adult team before transfer. There were also some important messages for commissioners in terms of how transitional healthcare does need to be funded, and the importance of an organisation-wide approach rather than just being driven by enthusiasts across some areas. The NCPOT study, again, it's useful to know about the recommendations from this because they are sort of fairly universal, but I'll explain what NCPOT stands for. So that's the National Confidential Inquiry into Patient Outcomes and Death. And essentially, they try and help with improving standards of healthcare by undertaking confidential surveys. And this particular study was looking at review of the barriers and facilitators in the process of transition of children and young people with complex health conditions into adult health services. And this is a slightly busy slide, but I'm just going to focus on sort of the key messages here, which was there were 5 key messages about making developmentally appropriate care core business for all involved, involving young people and parents and carers in transition planning and transfer to adult services, improving communication and coordination between specialties, organising healthcare services to enable young people to transfer to adult services effectively, and then having strong leadership at board and specialty level at all stages of transition and transfer. The NCPOT study also highlighted the sort of offering opportunities to young people to be seen independently and also embedding the HEADS approach in clinic consultations. So it's a holistic approach. It's about getting young people to talk so that we can listen, and it's a strengths-based approach. The HEADS stands for sort of having a conversation around who's at home, education, employment, eatings, activities, a conversation around drugs, alcohol, smoking, sexual health, mental health. And there are versions of this in terms of the T and the R, that's threads, so thinking about transition and medication and treatment. And so it's trying to understand the young person in context of their wider lives. So, for example, a practical problem could be a young person whose parents are in separate households, so they spend time between two households. So it's knowing that they have enough prescriptions that can be carried over across both households. Although it looks like a sort of big checklist, it's not really a checklist. It's about picking up aspects which are relevant for the young person in front of us, and then perhaps using separate consultations to build on some of these. And so the general thinking is using that sort of approach consistently from pediatrics to adults might sort of make it easier for the young person as they transfer and transition care. Some of the key recommendations from this study, are summarised in this slide, and some of them were at sort of healthcare professional level. And a lot of this will resonate in terms of what you've already heard. So having personalised transition plans, copying young people into correspondence, holding joint transition clinics, requesting input into the MDT, involving primary care. And at an organisation or trust level, having a central transition team, having an organisational transition policy, ensuring that that transition is included in the job plans of healthcare professionals delivering this, and ensuring our staff have appropriate training. And then there are some sort of national recommendations about having systems where young people can be identified so that they can be tracked as they're transitioning, and that it's specified in service outcome measures. So what are the simple things? What are the quick wins? Consider having a slightly longer appointment for young people, so it's tailored. Young people being copied into letters, I think that's particularly important for pediatricians or the children's services, because we're so used to directing our consultation to the family or copying the family into letters. I think it's recognizing that once they're age 16 and above, we should be copying letters to patients, and equally our sort of flow of consultation should be through the young person. Ensuring that the young person knows who to contact if transition is not going well. So who's that key worker? Encouraging self-management skills, and you've heard some of that before. Having a way of tracking the young person on our electronic health record, so being able to flag the young person, and then thinking about a sort of organization level, having resources on the web page that professionals can access, but also young people and families can access, and also training for healthcare to deliver developmentally appropriate healthcare. This was a nice review that was published quite recently on adolescent inflammatory bowel disease. And I'd included this diagram because it was just a nice representation of sort of the biopsychosocial factors that impact on managing adolescent inflammatory bowel disease, and then what the consequences can be if there are difficulties in any of these areas, which actually impacts on how we manage their inflammatory bowel disease. I've just taken out sort of the headlines of the titles of the various guidelines that have been published on consensus guidance on managing transition for adolescents and young adults with inflammatory bowel disease. And this is from the UK, from Canada, and from Australia. And the sort of elements are very, very similar to what we've talked about. Sort of the basic building blocks remain very, very similar. A nice systematic review that looked at practice and programs in inflammatory bowel disease transition care, and this highlighted that transition and medical related outcomes do benefit for adolescents with IBD, also benefit from structured transition programs. So thinking about all these different aspects. The summary was that the practice remains very variable, and there are no current standardized transition models for patients with inflammatory bowel disease. But importantly, it emphasized the importance of the multidisciplinary team, the importance of joint clinics of visits, the role of a transition coordinator, which is typically an IBD specialist nurse. This was a multicentric study of practice in the UK for transition services for pediatric inflammatory bowel disease, and this provided sort of real-world clinical data on the UK-wide IBD transition services. And it highlighted that over 90% of clinic services will have started transition preparation before the age of 16 years, and most transfer just after that, so generally between 16 and 18, but definitely by 18, which is mirrors practice across the UK. There is structured care with joint clinics, but there is variability in how this is delivered. And adolescent-specific topics are frequently not discussed, and so that's an area that we can all be better at. I was going to share an example of a transition pathway within our organization, and we do joint clinics. So it starts with a young person clinic, which they are invited to, and they would see a pediatric gastroenterologist with an IBD specialist nurse. And the idea is to cover the medical aspects of care, but also it gives the young person an opportunity to see one of the healthcare professionals, usually the specialist nurse, on their own if they would like to, and these are skills which are built on. And there's also time within the clinic, because we have slightly longer appointment times for our IBD nurses to spend a little bit more time with the young person around their disease education, their medication education, aspects of adolescent health, and also cover the differences and similarities between the pediatric and adult services. After they're seen in the young person clinic, they then attend a transition clinic, which is a joint clinic with our adult colleagues. So it would include a pediatric and adult gastroenterologist and a pediatric and adult IBD nurse. And following that, then a handover clinic, which takes place in the adult hospital. So our pediatric children's hospital is a different organization, and the adult hospital is a different organization. So there's a bit of movement of health professionals across the two hospitals. But in the handover clinic, the children's IBD nurse attends to support the young person and family, and they will be seen by the adult gastroenterologist with the adult IBD specialist nurse. And it is at that point that care would formally transfer across to the adult team. So there is flexibility in the pathway, in that they may have just one young person clinic, one transition clinic, one handover clinic if it's all straightforward. But if they need more transition clinics or more joint clinic appointments, then that would happen. It is underpinned by joint decision making. So we try, for young people on the pathway, we try and make decisions together in terms of change of medications, perhaps, or if they need a surveillance endoscopy or colonoscopy before transfer of care, we would offer to do that at the Children's Hospital. A visit to the adult IBD hospital is offered, particularly the sort of infusion bay, so that young people on infusions are familiar with the environment that they will be transferring to. We do have bespoke cross organization, because we're different hospitals, histology and radiology MDTs, to discuss any complexity that needs joint decision making during transition. We often try and attend our adult colleagues' biologics MDTs if we need discussion or there are decisions that need to be made in terms of changing medications during transition. There is joint adult and surgical team involvement as appropriate. Within our trust, if a patient has marked complexity and they're under multiple specialties, we can refer them to our central transition team, who provide that added layer of sort of support. And then recently we've tried to use validated tools such as the Mind the Gap, which was validated in the rheumatology world, to try and capture patient experience on transition, because that then helps improve and develop our pathways further. This is just a quick snapshot of sort of a similar pathway if we're not transitioning to our neighbouring adult trust, which is where most of our young people are transitioned to. But if we are transitioning to other hospitals geographically located at a distance, then we try and follow the same sort of process in terms of their preparation via the IBD nurse-led clinics, but they may not be a joint clinic. And what might happen is sort of a medical summary of care sent to our adult gastroenterology colleague, but we continue to hold care at the Children's Hospital until formal transfer of care. And usually that might be that they meet with the adult colleague, and then they come back to the children's for a final appointment, and then care is formally transferred across. So what do the IBD specialist nurses do? A huge amount. They provide a huge amount of support around education and preparation before care is transferred. This includes fortnightly telephone clinics with young people aged over 14, and they do try and encourage speaking to the young person alone, but this is often very young person led. They will undertake ad hoc discussions around transition or adolescent health while a young person is in hospital for infusions or appointments. They're often the named or the identified key worker, and they provide that continuity by supporting the young person through the young person clinics or transition clinics and the handover clinics that happen in the adult hospital. They also provide information, education, and training, and try and support sort of the wider life for the young person as needed. They use the heads approach in their consultations, so they provide the education about disease and medications, but also about lifestyle choices and signposts to appropriate support networks. And a lot of work they do is about encouraging that young person to be more independent and to be responsible for their own care and treatment. It's just worth being aware of the Ready Steady Go program, and that's a series of longitudinal questionnaires, again, designed to help empower young people with the knowledge and skills that they need to manage their condition, with a mirror sort of questionnaire when they have transferred and led by the sort of adult team.